When we think about patient voices in wound care, it's very much the cornerstone for innovation, research, and development. Despite a shift in generational medicine and nursing, for example, a change in the way patients access, rely, and find healthcare, people still very much have a voice in terms of their choice, their understanding, and decision making. We as clinicians need to support patients in the adjustments to how healthcare is delivered in terms of technology and how the world is changing, sometimes at a very speedy rate. We need to take patients with us to ensure they continue to engage with the people we care for. If we do not ensure the voices of patients are central to everything, this will potentially affect every area of healthcare, from health promotion, timely treatment, and diagnosis and healing. If we ignore or overlook the patient voice in wound care, we truly miss out on the most important factor in wound care and ultimately why we do what we do. One of the reasons for successful practice engaging with patients is the abolishment of hierarchy and power play between clinicians and the patients we serve. We exist to care and improve life for those in need, and this mindset has created a unique environment to work in, one built on equality, balance, and respect between clinician and practitioner and service users. Ultimately, we are the same. People struggling for the common ground that once established results in engagement and improved service user experience. This is a continuous negotiation and learning area that requires reflection, both individually, as a clinician, and together with our patients. In today's session, we will be discussing putting patients at the heart of wound care decision making. We are going to explore this concept as a philosophy, but also as a formal negotiation and relationship. Our patients are decision makers, experts, and leaders in their own care. Ultimately, patients have a right to both be actively informed, engaged, and empowered in their wound care to make choices about the treatment they receive. Times are changing. We no longer work in a healthcare system or with a generation of service users who have limited insight into their condition, treatment options, and their place or position in their wound treatment. People living with wounds have choices, they have a voice, and they also have the human and legal right to access informed, competent, and evidence-based wound care. The UK government back in 2011 termed the phrase "nothing about me without me," with the vision of placing patients' needs, wishes, and preferences at the heart of clinical decision making, a vision articulated by the Secretary of State for Health at the time, Andrew Lansley, and this was formally published by the King's Fund. The document clarifies what is meant by the term shared decision making and what skills and resources are required to implement it, and it also outlines what action is needed to make this vision a reality. The principle of shared decision making in the context of a clinical consultation is that it should be supporting patients to articulate their understanding of their condition and of what they hope treatment or self-management will achieve. It's also about informing patients about their condition, about the treatment or support options available, and about the benefits and risks of each to ensure that patients and clinicians arrive at a decision based on mutual understanding. The paper outlines the importance of communication skills and sets out how clinicians might approach consultations to arrive at shared decisions. It also suggests that tools that help patients in making decisions are just as important as guidelines for clinicians. As clinicians, we have a moral and professional duty to place patients central to their care, to assess and treat them holistically. I refer to the recent UMA document published by the Journal of Wound Care in 2020. Here we have practical tools to support person-centred care, therefore supporting our understanding of patients, promoting engagement and empowerment. We as clinicians are not in charge. In fact, we have no power or authority over patients. We are in positions of professional trust and privilege, and once we establish these foundations in our patient-clinician relationships, we can and will engage with people living with wounds. We need to build authentic relationships with patients. I refer to my work with the homeless community. Without true engagement, respect, and care, I would not have been invited into their lives or shared their experiences or life stories. Although COVID 19 has arguably left people shaken, there is no doubt that patients living with wounds will emerge from this global pandemic thinking and living differently for several reasons. Many have had to self-care or manage their wound due to isolation, due to the reduction in access to primary care services and or living in rural areas. Patients have embraced self-care and now may ask or wish to continue participating in this. Services are still reduced in parts of the country, here in the UK, and we are still playing catch-up. We need to explore the options of how to safely and sensibly continue wound care for the growing numbers of chronic wounds worldwide. True engagement is the ability of a practitioner to work in a way that successfully empowers their patient to make informed choices and to continue to work through times of challenge. This is the key with wound healing, and we know chronic wound management is not straightforward and healing can be delayed. Engagement is the key to overcome these obstacles, to ensure we continue to manage some of the wound challenges despite the issues that may arise.